discuss. So we'd like to discuss either a good randomized control trial or an original article, which is usually a prospective, even a observational study or a cohort study. But because this last surgical society meeting, we presented systematic review, I thought it would be appropriate for us to have a journal club on a systematic review, because it will reinforce all the very good points that Sania brought out in terms of what the systematic reviews objectives are and how to do a systematic review. So I thought it will be a good exercise to have a so I actually gave them a series of studies. Some of them were randomized control trials, some of them were meta-analysis, some of them are systematic reviews, and they chose this particular article. So without much ado, we'll hand it over to Nikitha to start the journal club. I think this is a very good paper, and I think we'll have a lot of good discussion. Okay. Over to you, Nikitha.
Good evening, everyone. Welcome to today's journal club. So the title of our study for discussion today is Clinical Outcomes of Medical Management Options for Chronic Anal Fissures in a Long-Term Follow-up, Systematic Review and Meta-Analysis. It's a Sierra Arango et al. Study. It's from Bogota, PC, Colombia. It's published by S. Kregaregi Basel, and it's a systematic review and meta-analysis. It was received by the publication on November 16, 2021 and was accepted in October 31st, 2022. Anal fissures are linear ulcers extending from the pectinate line to the anal margin, affecting the anodome and covering the lower half of the internal anal sphincter. Fissures persisting for longer than 4 weeks or recurrent fissures are generally defined as chronic anal fissures. The diagnosis is entirely clinical, with the presence of visible sphincter fibers at the fissure base or anal papillae or sentinel piles and indurated margins. However, some clinicians define chronic anal fissure with the presence of signs or symptoms. Pathogenesis remains controversial. Surgical treatment has been the main approach, with healing rates up to 90%. However, higher rates of incontinence ranging from 0 to 27% have been described, with persistent incontinence up to 9%. In the recent years, topical and oral treatments have been an important therapy option. Glyceryl trinitrate, calcium channel blockers, and botulinum toxin being the most studied drugs in various systematic reviews. One of the main cause of variability of response to treatment is combination of oral and topical treatments in the same analysis, as well as the different follow-up periods ranging from 4 weeks to 2 years. So the aim of this study was to evaluate the effectiveness of local treatments with calcium agonist, nitroglycerin, and botulinum toxin in the healing of chronic anal fissure in adult patients, as well as to identify the rate of recurrence. A systematic review and meta-analysis developed according to PRISMA guidelines and registered in Prospero. A systematic literature search was conducted through Medline, Embase, and Web of Science and Cochrane Library databases. The literature review was performed between September 2017 to August 2020. I would like to just point out the PRISMA guidelines. PRISMA is preferred reporting items for systemic reviews and meta-analysis. It has a flow chart which has 4 phases. There's an identification, screening, eligibility, and the included studies. And there is a 27-point checklist for the of the PRISMA guidelines, which includes the guidelines regarding title, abstract, introduction, methods, results, discussion, and funding. The inclusion criteria of this study was publications had to have a clinical definition of chronic anal fissure with at least one of the following signs or symptoms. Those are visible sphincter fibers at the base of fissure, anal papillae, sentinel piles, indurated margins. The symptoms had to be chronic for at least 4 weeks, and the treatment option had to be medical interventions. And the studies of English, Spanish, or Portuguese publications are included in the study. Exclusion criteria had studies with surgical treatment or oral treatments or combination of these two. The data of these studies were extracted in an Excel spreadsheet. General study data, clinical characteristics of participants, chronicity of the fissures, diagnostic methods, and different treatment strategies were segregated. 3 outcomes were evaluated. Those are cure rate, recurrence of clinical symptoms, and adverse events. Quality assessment was done using Cochrane collaboration tool. These included domains such as random sequence generation, allocation concealment, blinding of participants, staff, blinding of assessors, incomplete outcome data, and finally selective report. Cochrane collaboration recommends a specified tool for assessing risk of bias in each included study. This complies and judge and a support for the judgment and a support for the judgment of each entry of risk bias table, where each entry addresses a specific feature of the study. The judgment of each entry involved in the study assesses the risk for bias as low risk, high risk, and unclear risk. This is an example of a Cochrane collaboration tool, how it is plotted with studies on the one side and the features of the study on the other side, specific feature of the study. Random and fixed effect models were used to calculate the combined outcome of the binary data. Publication bias was evaluated by Beggs and Eggers test and graphically by funnel plots. Publication bias is the failure to publish the result of study on the basis of direction or strength of the study findings. If you plot the results of the studies included in a funnel plot, if they are at the center of the funnel plot, it shows low publication bias, but if they are deviated more on the one side, it shows high publication bias. There are many tests to assess the publication bias, but most commonly used are Beggs test and Eggers test. Beggs test assesses if there is significant correlation between the ranks of effect estimate and the ranks of their variance, generally plotted by funnel plot with study result on the one side and study precision on the one y-axis, with overall effect is plotted at the center of the study. The study which are far from the confidence interval are considered to be of publication bias. Eggers test uses linear regression to assess the relation between the standardized effect estimates and the standard error. So it is generally plotted in a linear graph which shows the study being plotted on the either sides of the regression line.
Have you got any pictures, Nikitha, of example of a Beggs or Eggers test?
No, sir, but I just got the generalized plotting.
Yeah. Okay. Have you finished now? Have you come to the
one point, sir?
Yeah.
The p-value for the Beggs test and Eggers test are calculated, and if the value is less than 0.05, it is considered as publication bias is present. If the value is greater than that, it shows there is no publication bias.
Okay. Pawan, critique of the paper so far? Hello? Pawan, are you there? Hello? Vinod?
Sir, I think Pawan is not logged in. Pawan is not logged in.
Not logged in, huh? Okay. Pawan, are you there? Hello? Pawan, are you there?
Sir, I think Pawan is not logged in. 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 No, I don't think so. He's not there.
Indraja, are you there?
Illa. No, Indraja also is not there.
Okay. So Vinod,
Hello, sir.
what are the critique of the paper so far?
Sir, Prones, it's a systematic review, sir. And they have clearly mentioned the definition of what they have included, basing on that what is chronic anal fissure and that. And it is a recent study, sir. And clearly mentioned what they are including, inclusion criteria.
Correct. Praveen? Praveen,
Sir,
are you there?
yes, sir. Yes, sir.
Yeah.
Sir, same as it, sir. It is a recent study.
No, don't repeat whatever Vinod
yes,
has
sir.
said. Is there anything to add?
Sir, cons, there are only few studies they have included in this meta-analysis, sir.
No, if you look at it, they have looked at about 186 papers.
Yes, sir. But only 17 were of this
so
topic, and they have selected. Sir.
Why is it a good thing or a bad thing?
So, for analysis, it will be very less papers too, sir.
No. Okay, I think you have not understood what Sania said. So let us go to Abdul and Sania. Abdul, what do you think of the critique so far?
Yes, sir. Anything to add? I don't think so. I have anything to add because the
Sania is the master of systematic review.
Nothing like that, sir. I feel they have done an extensive search, sir, and also they have, like, we didn't have access to Embase. They have access to Embase also.
And
so they
also
have done an extensive search. Yes, sir. Cochrane
also.
Yes, sir. Yes, sir. Yeah. And they have followed the Prisma guidelines properly, sir. Only thing I am not sure about is the bias calculated by those tests. I'm not familiar with those two tests.
Yeah. See, I think basically, Praveen, to answer your question, see, if you go through a lot of databases, for example, they have gone through all the large databases, DOAJ, Google, I think they have not gone through Google Scholar, and I think that is one that they have left out, and Scopus, but all other major databases they have gone through. And they have, what they do with systematic review is you have to follow the Prisma guidelines. So it doesn't, you have to, the important thing is to go through as much of literature that is possible, all the articles that are there. Once you put the Boolean operators and search, and they have also used the mesh terms also, which is medical headlines, medical MESH, what is this? Medical subject headlines. So they have used the mesh, and also they have used the Boolean operators. So by doing that, you will virtually get all the journals, that all the articles that have been published. Then you have to have, rigid criteria, so that you then only look at the journals that actually follow they fulfill those criteria. So it doesn't matter if there are only 17 studies, but those 17 studies are robust, which is why they have only looked at them and not looked at the other 100 odd, 150, 160 odd, which they have actually rejected. So that is actually a good thing. So it's not a bad thing. Okay, do you understand?
Sir. Yes, sir. Understood, sir.
Okay. Nikitha, now you come to your critique.
Yes, sir. Pros of the study were that it's a recent study with a relevant topic, and it's a systematic review and meta-analysis, and they followed Prisma guidelines all through. They had a clear definition to what to include and what to exclude, but the cons were Sir, if oral treatment is not considered as a medical management, I think the title of the study should have been changed to topical medical management, because oral treatment is also medical management.
Correct. Agree.
And I don't know if accepting after 1 year comes under con, or it's just
No, I think see, it
irrelevant.
takes time. See, it is not November to September. It's about 7-8 months. See, I don't think that is a major issue. It depends on how well the editor, how quickly the editor sends the paper for peer review and all that. So I don't think that in itself is a negative.
The follow-up is not defined,
for-
sir. They did not set up any minimal time for the follow-up.
Yeah, agree.
Yes.
Niranjan, anything to add?
Nothing, sir. Nothing, sir.
Srikanth?
No, nothing to add.
Ramakrishna, you have made a comment. Good evening, Ramakrishna.
No, they have taken they have taken almost 3 years to do this study. Actually,
Correct.
to analyze these 17 papers, I don't think it requires that much time. About 3 to 4 months must be more than enough for that. Why they have
Yes,
taken
but-
so much time?
Yeah, but if you looked at what Sania said, I think majority of systematic review takes about 2 years.
Yes, sir. Yes. Even
Sir, I
when
think,
the studies that we went through, it took a lot of time, sir.
Sir,
Even
I
though-
think they've gone through 180 or something, and then they have cut it down to whatever 17 or 18. So
Sir,
probably they
usually what they do, even though that number is 180, they won't go through the whole article. They will just look at the abstracts.
abstracts and this one,
And
yeah.
then they will decide whether to include or not to include. The other thing is they are not defined what is the minimum duration of follow-up, what is the minimum duration of the chronicity. Some of them are just 4 weeks, some of them are 3 months, some of them are 8 months, like that. Lot of variation is there. Even
The minimum
for,
they have defined is as 4 weeks, but there is variation. I agree.
and then if you want to compare, you should have something rigid, like some of the this follow-up period. For example, if you take some of them are just 8 weeks, some of them are followed for 1 year.
Yeah. Correct. So that those are the cons for the study. Okay, carry on. Ma. Continue.
Yes, sir. These were the 17 studies which were included in the study after reviewing the 189 studies. Sir, I just wanted to ask regarding one unusual thing I have seen, sir.
Yeah.
In diagnostic approach, they have mentioned manometry along with clinical and proctoscopy, other imaging studies.
Yeah.
So manometry, would you share any information regarding that, sir, in anal fissures?
See, the important thing about there is a sea change or a shift in terms of your approach to anal fissures. Especially with regards to women. See, women because they are prone to developing perineal tears, possibly injury to the pudendal nerve, and then also chronic pudendal nerve latency problems relating to prolonged labor and things like that. Even though there has been no what shall we say, structural damage to the anal sphincter complex. So because of this, you have to be extremely careful in terms of offering surgery for patients who come with fissure, whether it happens during pregnancy or later. In terms of young males, there is not much of a problem, but in women, you have to be extremely careful, because in young women who come with fissure, who have not yet completed their family, then if they go through pregnancy and then they have perineal problems, then if you have done a sphincterotomy on them, then you may add to the problem and they develop incontinence. So which is why it is recommended, especially for women, that you do an anorectal manometry, and those with very high anal sphincter resting, what we call as resting anal sphincter tone, and a pronounced rectal anal inhibitory reflex. Only such patients you offer sphincterotomy or otherwise. Now the current standard of care is to try medical management, and only in such patients who medical management has failed and patients develop recurrent fissures, in such patients and in those patients who have high resting anal sphincter tone, only in such patients you offer surgery. So that is where this anorectal manometry comes into play. Niranjan?
What should be the pressure above which we should offer surgery?
That depends on the instrument that you use. I don't think there is anything standard. The anorectal manometry, I think it is individualized. What they set as but I think I don't want
Some
to
general guidelines, Bekalwa.
I at the moment, I'm not sure as to what is the pressure beyond which surgery is recommended. I will find out and I will let you know.
No, ask the PGs to find out, man.
Andre, I will also find out. They will also have to find out. Ramakrishna, do you know, sir, what is the minimum pressure over which you recommend surgery?
Give this to first year PGs.
No,
Niranjan,
I don't know, sir, because we don't use in our daily regular practice.
Correct. That is
we don't know that. We don't know that.
Because in future it may become medical legal also.
I think we need to know, but I don't know at the moment. But that's, I think those are the two parameters they look at: resting anal sphincter tone and pronounced rectal anal inhibitory reflex. These are the two things which they look at when they recommend surgery. We will find out the pressure. PGs, Nikitha, please find out.
Sir,
First year
I have
PGs.
looked it up, sir, actually, before the presentation. So
Yeah.
basal pressure as well as the maximum possible pressure are measured, sir. Basal for a normal adult individual is around 65 to 70, sir. Whereas the high-end pressure shows around 135 mmHg, sir. That's what they mentioned. And it will vary for hemorrhoids and fissures. It will increase, sir.
Okay. So you understood.
If it is above 130, you have to operate. Huh?
No, sir. The 135 plus or minus 5 to 10 is average, sir. But I don't know the guidelines for when to operate, sir. I just saw the studies which were conducted.
Just find out. Out. We will also find out.
Yes, sir.
Okay, carry on.
17 studies were included, which ranged from 2001 to 2012. And most of them had the variable chronicity. And all the studies had intervention and a comparator. But the study population was double digit in almost all the studies. The parameters which we segregated in the spreadsheet, which the studies segregated in the spreadsheet were age, intervention, diagnostic approach, treatment duration, heel intervention and heel control, adverse events and their control, and type of adverse events and recurrence rates. The follow-up time was also mentioned. Before going to the individual analysis of the studies, I would like to mention about few terms, which is Mantel-Hazen test is a test used to analyze of stratified or matched categorical data, just like each individual study which we are going to see had two different interventions, and we are going to assess the association between them using the Mantel-Hazen test. The confidence interval is the probability that a population parameter will fall between a set of values for certain proportion of times. Analysts often use confidence intervals that contain either 95% or 99% of expected observations. And the relative risk or risk ratio is the ratio of probability of outcome in an exposed group to the probability of outcome in an unexposed group. These are the components of a forest plot. Most of the meta-analysis are represented by forest plot, which has study group, which has a table including the study group and intervention and control groups, risk ratio, weight percentage of each individual study, all of them together contribute to 100%, and the risk ratios, and they are plotted with a forest plot. It has markers where the width of the marker represents the confidence interval, and the summary of the analysis is represented by a diamond shape. The position of the diamond shape represents the effect of the study. What is it favoring, whether the first intervention or the control? The width of the diamond also represents the precision of the study. The three outcomes which were published in this study are healing, recurrence, and adverse events. In the healing, the first table showed comparison between diltiazem and glyceryl trinitrate ointment. As you can see the diamond plot is on the side of diltiazem, showing that it has more healing properties than the glyceryl trinitrate. This nifedipine versus lidocaine shows favors nifedipine, and botulinum toxin in comparison to glyceryl trinitrate, it almost shows an equal effect with slight deviation towards botulinum toxin. Botulinum toxin compared to isosorbate nitrate shows relatively more towards botulinum toxin favors. The recurrence rates, calcium channel blockers, diltiazem versus glyceryl trinitrate shows no much difference in the recurrence rates. Nifedipine and lidocaine, nifedipine shows high recurrence rates in comparison to lidocaine. And botulinum toxin and isosorbate nitrate, botulinum toxin shows high recurrence rates. In adverse events, diltiazem has more adverse events in compared to glyceryl trinitrate.
Less adverse events, ma.
Sir?
Glyceryl trinitrate has more adverse events compared to diltiazem, no?
So, these are the reported events, sir. So this shows more association with the adverse event, the diamond plot.
Yeah.
So that has to mean diltiazem has more association with the adverse event in comparison to glyceryl trinitrate, sir.
So, but glyceryl trinitrate went out of favor because of the severe headache and hypotension it used to cause compared to diltiazem. Diltiazem doesn't have many side effects at all.
Diltiazem is now more frequently used than glyceryl trinitrate.
Correct. I think you have not understood the thing. I think it is basically the less events would be on the left hand side and more events on the right hand side. So because it is less, the diltiazem has less side effects compared to the glyceryl trinitrate.
Okay, sir.
Continue.
Nifedipine and lidocaine almost equal distribution in adverse events. And botulinum toxin has less adverse events in comparison to isosorbate trinitrate. No publication bias was observed. Beck's test showed p-value as 0.181 and Egger's test showed p-value as 0.6. There is a presence of atypical data, but majority is within the band that represents the confidence interval of the model. Discussion. This study included 17 articles after an exhaustive search in the main medical databases. Remarkably, the number of calcium channel blocker studies was higher, that is 12 in number, than the botulinum toxin studies, which were 5 in number. Calcium channel blockers showed greater efficacy in healing, showing a better outcome when using nifedipine than when using other treatments. Botulinum toxin compared with other topical treatments showed no superiority in cure of chronic anal fissure. It can be considered as a strategy for patients presenting adverse event to topical treatments or unable to comply with application regimen. In conclusion, this meta-analysis documented that the use of calcium channel blockers to heal chronic anal fissure is more effective in compared with the other treatments in a long-term follow-up. Further studies are required to understand the underlying factors related to the healing process and better clinical prognosis of chronic anal fissure, including large local or regional multi-center randomized clinical trials.
Okay. Critique. Now, Vinod, what do you think of the study? The results?
Sir, they mentioned clearly, sir, but my confusion is in all these 17 studies, they used all these drugs, sir, or
No, they have said very clearly, no? See, 5 studies compared botulinum, and the remaining 12 studies compared calcium channel blockers with other medication. So in the
calcium channel with glycerol trinitrate mainly.
With glycerol trinitrate, isosorbide nitrate, and in the botulinum, it is compared to calcium channel blockers.
okay, sir. Then in a systematic,
Right.
basing on in a study, this study is based on only chronic anal fissure, sir. We can separate the treatment, sir, when we are taking a systematic review.
I didn't follow your question.
No, sir. For a systematic review, when we select papers, we'll take the papers which are on the same thing, sir. Topic.
No. See, no. They have actually clubbed everything as topical application. Medical management of chronic anal fissures.
Okay.
So they have looked at studies which looked at calcium channel blockers and botulinum toxin.
Yes, sir.
Abdul? Praveen first.
Sir, they have done detailed analysis, sir. And I have a doubt, sir, in the recurrence intervention, number of recurrence intervention, they have given a number, but they have not mentioned what was the intervention done, sir, for the recurrence.
What do you think would be the intervention?
Surgical intervention, sir.
Correct.
But
this paper is not all this thing concerned about surgery.
So that is why they have not discussed the surgery, but the intervention will have to be surgery because there is nothing else left.
Failure of medical management is surgery.
Yes, sir.
Okay. Abdul, your critique.
Sir, all the points, all what they have included, how they have done the study is good, sir. They have used the standard guidelines and all to do it. Nothing else I can add, sir.
Tanya?
The same, I felt they have done it in the prescribed manner only, sir. I could not find anything.
Niranjan, what do you think of this results?
Sir, they have done it as expected. I don't think there is any lacuna in that as of now. The results are also it's known that diltiazem and nifedipine are more effective better than glycerol trinitrate with respect to side effects as well as the results. So nothing new in that.
And botulinum toxin has not come out better than the.
Yeah.
But
correct.
It's very much more expensive, botulinum toxin.
Correct.
Ramakrishna sir?
Sir, actually, when we say systematic review, they have to analyze the results of paper and then give their own opinion, depending on that. But in this paper, everything is on the meta-analysis only. What is the systematic review part in this? Because if you read only systematic review, they will analyze each study, what conclusion they have given, how they differ between studies, and then club it together, and in the end, author will give his own conclusion.
Correct.
Based on this. That part is not there at all. So the study can be called only as a meta-analysis, not as a systematic review. That is one thing. And if you look at the diltiazem results, this table 3, most of the studies, the difference is not significant. Only one study, it has pulled the whole result. That is one thing. See, if you see 1, 2, 3, almost 7 studies are there.
Yeah.
Out of 7 studies, only the first study result is significant.
Correct.
1.53. Rest all statistically not significant. This risk ratio.
Yeah.
And how we say statistically not significant means this confidence interval, if it contains 1,
yeah,
then it is not significant. See here 0.79 to 1.28 means 1 comes somewhere in between that.
Correct.
So if this range includes 1, then that result is not statistically significant. So this out of 7, 6 studies have given results which are not statistically significant. Only one study, that is that first one, Alas 2012, out of 36 patients. So only that study has given a significant difference between diltiazem and glycerin trial nitrate. That is one thing. Secondly, if you see some of these articles, I didn't go through every article, only 2-3 articles I went through. They have all used chi-square test to compare these 2 groups. But here they have taken risk ratio. Risk ratio is used when you have one group of patient exposed, other group of patient not exposed. That usually typically comes in a case control study. But to compare 2 groups in these randomized studies, this difficult to interpret this risk ratio. I don't know why they have used risk ratio as when all the studies, if you go through that original articles of whatever they have mentioned, they use chi-square test to compare the groups. But these people have used this risk ratio. But I don't know what happens if you apply chi-square test to these results and see whether it is significant or not. Because even the overall risk ratio here, it shows 1:1.6. It is a very small difference, I think. That's, we don't know how significant they are. That's one thing I could not understand. And the one study, actually, that first study they have mentioned in the table 1, no? They have used changeover, crossover study, this one. Because that first study, they have used botulinum. And if they don't improve, then they will give this other drug, local drug. And if they don't improve with both, then they will use them combinedly. This type of crossover study it is. It is not a comparative study, this first one. They should have excluded this. They have included that study also. That's a wrong thing. All the study I could not open and see. Only 2-3 I opened and saw that.
What do you think of the NNT? NNT is adequate or not adequate?
For some, it is, see, 250, they have shown 250 for botulinum toxin. That means to get result significant for one patient, you have to treat 250 patients. It is, it's not significant, means the difference is very less. Means you cannot recommend this particular treatment when NNT is something like 250. For many things, they have written like that.
Correct.
For botulinum, it is 250. For calcium channel blocker, I think 12 they have written.
237.
Means
237.
237 is too much. Means
Again,
to get the difference of treatment between these 2, you have to treat 237 patients to get one improvement.
Correct.
That is not acceptable. Means you cannot recommend this treatment. That means there is no difference between these 2.
Correct.
And
Srikanth?
they have, yes, sir.
Srikanth?
Yeah, nothing to add.
Nikitha, you show whatever your critique, ma.
Sir, you were saying some NNP, sir. I couldn't understand that.
See, number needed to treat. NNT means numbers needed to treat, which means if you treat so many patients, then you can show a difference between the 2 groups that you are treating. If the NNT is small, that means one treatment module is better than the other one. You followed?
Yes, sir.
let us say you are comparing drug A and drug B. If you have an NNT of about 50 or 60, which means if you treat 60 patients, you can show a significant difference between the two groups. On the other hand, if the NNT is high, that means the difference between the two groups is quite small, because you are needing to show, treat so many patients to show a small difference. So that is why the NNT becomes important when you are comparing different treatment modalities.
Okay, sir.
Okay, you show the critique. Yeah.
Yes, sir. My critique is the pros of the study are it had a Prisma chart, and it is a meta-analysis. And as sir said, I couldn't place systematic review in the pros because there is no supporting evidence for systematic review to be added to the title or to the study. And the bias is minimized by using Cochrane collaboration tool, and individual parametric analysis was done. The cons of the study were the follow-up period ranged from 8 weeks to 18 months, which is very variable, and I think it affects.
Nikitha, you can't call this as a con of this study because those are the cons of the other studies which have been published.
Yes, sir.
They can't have the control of follow-up. They were
They
only
had-
analyzing.
Yes, sir. But I thought if they could just define any follow-up period, like
control.
minimum of 1 year or something like that,
Nikitha,
it would have made a difference. Yes.
Nikitha, they have only
Yes, sir.
looked at all the studies which manage medical management of the chronic fissure in anal. So they have no control over the how many months for the follow-up. You can definitely say because the follow-up is variable, some of the conclusions they have made may be not accurate. But you can't say that it's not a con or it's not against this study itself. Do you follow?
Yes, sir.
But still it becomes a limitation, sir.
Limitation, definitely. It becomes a
Limitation, and it is a negative point only because you can't use this conclusion to your day-to-day practice. This conclusion is questionable when so much of variation is there. See, in one study there is only 8 weeks, another study 18 months. How can you club those two results and compare? Because they are not, they become uncomparable. If you follow this 8 weeks to 18 months, probably you would have had some more recurrences or some more healing. So that will skew the results and data. So the conclusions
probably they have included
accepted.
because only limited papers, even though they have searched through so many this thing, they've got only 17 papers with this.
Yeah.
So that's why they probably had to do that.
In that way, for a systematic review, it is all right, sir, because they will be analyzing only the results, conclusion, and they will take out what is the summary they have given and analyze it. But if you are clubbing those numbers, then it becomes questionable. It skews the data and results.
Nikitha, do you know they have used the word fixed effect and random effect? What do you understand by fixed effect and random effect?
Sir, fixed effect and random effect. Random effect is used when there are variables that gives variable effects, sir. Whereas fixed effect model shows the same result even on changing of the variables.
No. Anybody else? What do you understand by fixed effect and random effect? Because they have used that to reduce the bias.
Yes, sir.
Anybody else? Abdul? Sanya? See, the fixed effect is uncertainty only within the study. So if there is uncertainty within the study itself, then you use it is called a fixed effect. If there is uncertainty both within the study and the comparative studies that you have made, that is intra and inter study in uncertainties, then you call that as a random effect. So you use both of these to see how much bias is there in terms of selection or reporting and things like that. So I think that is basically what they have done to try and reduce the bias. See, but I think they have also admitted that however hard you try, when you do a systematic review or a meta-analysis, it is only as good as the studies that you have actually compared and analyzed. So if there is bias in reporting or selection bias in that study, there are tools which will try and reduce the bias, but it will never be zero. And even then you can cleverly apply the tools to try and reduce even though there is bias, you can still make it appear as if there is no bias. So there is always those things that happen. So you have to take the whole study in total to see what is the sum effect of the analysis that they have made. I think I agree with Nikitha that there is more meta-analysis component in this study rather than the systematic review. They have not actually they have not given their opinion about the study itself. Okay, you have studied some other comparisons, no?
Yes, sir. And sir,
yeah,
the thing I put random and fixed effect model in cons because few in the analysis, few of them they have used a fixed effect and few of them they have used random effect, sir, and did not define any criteria for that within the same outcome, sir. So
I think maybe Ramakrishna will be able to explain that. I'm not competent enough to explain that. Ramakrishna?
No, sir, I have not come across this concept very frequently. We have to study further. Only thing they say, what you explained, that is right. Only thing, in the fixed effect module, the investigator fixes some effect size, like this much of sample size should be there, this much of results we can accept, like that. They will fix it and then they are study. In random effect, they don't fix any of those numbers. Like that it goes, because here they have not fixed any sample size, like whether it is 15 they will accept it, whether it is 100 they also they'll accept. They have not fixed anything number like that. So probably that's what they meant by random effect. But I'm not very sure. We have to study it further.
And also, while mentioning the results in the tables, they have used calcium channel blockers and nifedipine as separate, sir. And few of them they have used diltiazem as the heading. I don't know the reason behind that. Even though both are calcium channel blockers.
Correct. Yeah.
Cross reference. I have used two studies. One of them is efficacy of topical spectrotomy treatments. These are by medical management. A systematic review and meta-analysis of efficacy of topical spectrotomy treatments for anal fissure of 2021. 37 studies met the study selection criteria and 17 studies showed glycerol trinitrate was significantly more likely to heal anal fissure than placebo. And 11 studies showed a marginally significant difference between healing rates of diltiazem over glycerol trinitrate. There was no significant difference in healing between diltiazem and placebo. So widespread use of topical diltiazem and more evidence is required to establish the effectiveness of the calcium channel blockers. So in this study, they have favored glycerol trinitrate, sir.
See, there is no doubt glycerol trinitrate probably is a better healer of the fissure, but because the major problem with this is severe headache that actually prevents people from continuing the treatment. So there is a major dropout of the patients. So which is why you can't really analyze how, if at all the patients continued for a period of 6 weeks, how many of them would heal the fissure. Probably, I think glycerol trinate will have a marginally improved results compared to other calcium channel blockers. But because of the fact that it has significant side effect in about 33 to nearly 40% of people dropping out because of the severe headache they get, throbbing headache, because it causes cerebral vasodilatation.
Yes.
Right. What is the next reference?
Sir?
Only one or two?
One more, sir.
Yeah.
The other one is botulinum toxin injection versus topical nitrates for chronic anal fissure. It's an updated systematic review and meta-analysis of randomized controlled trials of 2017, sir. 6 cities were describing 393 patients were included. There was significant heterogeneity among the trials. On a random effect analysis, there was no significant difference in incomplete fissure healing or recurrence between botulinum toxin and topical nitrates. Result being botulinum toxin is associated with fewer side effects than topical nitrates, but there is no difference in fissure healing or recurrence.
Yeah.
That's it.
So what is the take home message from these studies then? Go to your next slide.
Yes, sir.
So what do you think? What I think we'll ask the others. Vinod, with whatever you have heard today, will you alter your treatment strategy?
Sir, right now we are using lignogen and diltiazem, sir, and I don't think there is no new things which will again I'll add new things in the from now.
Okay. Abdul, will you change your practice?
No, sir. Conservative manage, but if you have a chronic fissure, we'll go ahead.
See, this is not for acute fissure, man. It is actually for chronic fissure. Will you still continue to use? Will you continue to use calcium channel blockers for chronic fissures?
No, sir. No, sir. I'm saying for acute fissure, we can give medical management.
But
and
this was
chronic.
Yes,
sir. If it is chronic and in ladies, we can wait and watch. But if it is gents, young fellows, we can go ahead and operate.
Sanya?
Same thing, sir. I would not make any change in the currently followed practice.
Right. Niranjan, what is your strategy so far?
Sir, that is what in a select group of patients, acute anal fissure definitely we will try conservative. In chronic anal fissures, in a select group of patients, like in younger females, like unmarried or not completed their family cycle, trial of calcium channel blockers, definitely will I'll try. And then probably if if it is not healing or it is troublesome, then only we'll go ahead with the surgery.
Srikanth, what is your clinical practice?
Chronic fissure surgery only. If they are
Even in
not
women.
willing, then I used to do lignogen. Now probably will try diltiazem.
Even in women, chronic fissures, you will operate straight away?
Yeah, more than 3 months, definitely.
Ramakrishna sir, what is your
Usually
strategy?
I operate one third of the sphincter, so risk of incontinence is not there.
Yeah, correct.
I never divide the entire thing, whatever the severity is.
Correct.
I've seen.
Ramakrishna, what do you do, sir?
Hello. Sir, if you ask based on this study, it is difficult to say because this study has not given any data regarding surgery. So
Correct.
you can't say I am discarding surgery in favor of calcium channel blockers. If you are using calcium channel blockers and nitroglycerin, perhaps calcium channel blockers are better. We can shift it. But if you are already using this, it's you have to continue. But there is no comparison to surgical treatment in this study. So based on this study, if somebody is doing surgery, he cannot change it.
Correct. So my take on that is that basically, I think what Niranjan said and what Dr. Ramakrishna and Srikanth said is true. As of now, for acute fissures, definitely medical management. In chronic fissures, if the patient, if you explain to them that there is a 60% chance of healing as opposed to 80 to 85% chance of healing in acute fissures, and if they want to continue medical management for another 6 weeks, and you have to ensure that they take, because it should not be due to lack of proper medical management. Because if they're discontinuous and if they're irregular, then you cannot be absolutely certain. So you have to ensure that you explain to them how exactly you should do the medical treatment. And then if they are willing, so 60% is what happens with the second go. That is when the fissure has already become chronic or recurrent attacks. So in that, I think this study shows that probably calcium channel blockers are slightly better compared to botulinum, and botulinum, though it is more expensive and does not show any advantage over the calcium channel blockers. So if you balance the cost effectiveness, then there is no role for botulinum in as primary management. If the patient has already been tried on glyceryl trinitrate or on diltiazem, then you may want to choose botulinum as a second option. And if either of these options fail, then surgery, obviously. But we are not talking about surgery because this study has not compared, as Ramakrishna said, surgery with the medical management. So that is the take-home message, as far as I am concerned. Nikitha, what is
botulinum is a single injection or how many injections?
Single injection. It is done under ultrasound guidance into the sphincter muscle.
Okay.
So it is also like sphincterotomy only, medical sphincterotomy.
Medical sphincterotomy.
It's a medical sphincterotomy.
Sir,
Nikitha,
Yes, sir.
what is your conclusion?
It almost includes what you have told, sir. Considering the medical management, preferring calcium channel blockers but most probably would be in practical situation, we would be going for a surgery. But the study, as far as the study is concerned, calcium channel blockers are better. But if the patient is non-compliant or they want something else but not surgery, we would go with botulinum toxins.
Okay. Abdul, you were asking something?
Sir, the role of fissurectomy, sir, is it still there? How is it? Or just sphincterotomy is enough for chronic fissures?
I think sphincterotomy is sufficient. The only thing is, if the fissure is very chronic and the edges are very indurated and
Fibrotic.
then you may excise the thing, because fibrotic ends will not heal. So then you might want to excise the fissure so that you freshen up the edges so that it heals faster. But there is no hard and fast rule.
And also those patients who have sentinel pile.
Yeah.
With a fissure, with a chronic fissure.
Yes. Okay, I think been a very good, I think Nikitha, Niranjan, your comment on how she presented. Srikanth, your comment.
Very good, very good.
Ramakrishna.
Yes, sir. She presented very nicely, and also she has done some background reading, and she has tried to understand some of the statistical jargons and some of the concepts, especially these random blocks, which we also missed it. So I think she has done a wonderful job.
Have become
very
experts
nice.
in statistics.
Yeah. They have been studying very well.
Nikitha, I think I agree with all of them. I think you have done a good job, very good job. You made an effort to, to cross references, also looked at statistics. So all in all, a very good presentation. I think keep it up. Well done.
Thank you.
And if there are no further questions,
thank you, everyone.
We will stop the meeting. Good night, everybody.
Night.
Okay, good night. Thank you, sir.
Thank you, Ram.